the case for the centre over quite a prolonged period, which involved a lot of science and a lot of political, with a small and large P probably, negotiations with multiple partners. So you've set us up very nicely, Alex. So thanks very much, and we look forward to sharing with you probably within the next hour or two the first draft, which is just about ready for submission now, of a paper that describes the work that Angela's just presented to you, which we're hoping to squeeze in somewhere reasonably prominent. So Spiros, over to you.
Can you see my slides?
Can indeed.
Okay, cool. So thank you very much for the opportunity to talk. And I just have a couple of slides actually on what different approaches we're taking to facilitate all the great research that Angela described and all the other ongoing projects within the TRE, particularly around phenotyping and with data curation methods. So as Angela said, we have a lot of data. So this is quite a sort of a pivotal moment where we have access to data that we never even dreamt of sort of a year ago. So we literally have millions of rows of patient data across multiple sources, and that brings many challenges. So we have multiple sources that all use different controlled clinical terminologies to record the data. By definition, these terminologies are different in resolution. Some are very, very fine-grained, others are coarser. The information is captured at different time points, and that again needs sort of investigation before we can actually start defining algorithms to extract sort of diseases or risk factors. And data quality is variable between sources and across sort of different temporal windows. So all of this means that when we want to define algorithms to extract diseases or biomarkers or sort of risk factors for these data, it takes a long time. So one of the main sort of motivations of our work is working within Angela's methods group is to define sort of methods to define all of these diseases and risk factors and biomarkers from the data in a reproducible way. So we want to be able to sort of build tools that enable researchers to not have to recreate algorithms from scratch, but combine existing algorithm definitions and instructions in a reproducible way in order to transform the raw data into something that they can use for research. And that will sort of span not only creating the algorithms, but also evaluating them. Because again, we're in a quite unique position to have a very large cohort that's all-encompassing, large amounts of follow-up time, and the fact that we have multiple sources that each contribute a different aspect of this sort of patient pathway. So we can start looking at agreement between the different sources and agreement sort of in terms of both kind of prevalence and incidence, but also in kind of prognosis. So that's sort of a very exciting sort of ongoing type of work that it's not sort of a project that's going to start and finish, but it will be ongoing as our understanding sort of all the data sources and all the processes in which the data get generated evolves. So that's kind of like the broad motivation of what we're working on. So a concrete example of what we've started to look at is defining a COVID-19 infection phenotype within all the TRE data sources, and then defining sort of COVID severity. So we have multiple sources that can define COVID infection, and all of these sources capture information in different ways. So the first sort of part of this, and this is work that Johan and Chris have been sort of leading, collaborating with many others, is to look at what all the sources can contribute, what information they capture, and how we can start looking at how to define severity. And severity, even just by looking at the existing projects that we have in the TRE, everybody thinks of it in sort of different ways. So you can have severity, but just by using a marker that someone was hospitalized, or you can have severity when someone was hospitalized and intubated. So there are multiple sort of grading in that phenotype on how to define it. So the idea is to sort of bring together a group of everybody who's interested and start developing this algorithm and validating it in the TRE data. And I think we're in a quite unique position to be able to define this phenotype at a national level, I think probably globally, using the data that we have. So obviously this is a really nice segue at the long COVID sort of work that will be ongoing within the TRE with Jonathan Stern and Nish Chaturvedi and Kathy and others. And sort of it will complement that work of once you have defined the COVID sort of positive phenotype and the severity, can you define reinfection, and can you define long COVID and characteristics of long COVID and post-COVID syndrome. So that's sort of an example of defining a phenotyping and evaluating it in the TRE data sources. Another sort of stream of work that we're working on is doing all of what I described in a machine-readable and reproducible way. And the idea is that every phenotype algorithm that we have is stored in a machine-readable file format containing all the metadata that's related to that algorithm, and sort of CSV lists of all the SNOMED CT concepts or the ICD concepts, or all the concepts that are defined in that particular algorithm. And we've done quite a lot of work already, thanks to Will and Ami, on reviewing sort of lists and lists of codes on defining sort of the main cardiovascular diseases that we're looking at. But obviously, there's a plethora more of diseases that we want to curate and to define and to evaluate it. So we definitely need more volunteers to help us sort of review these algorithms and sort of create pragmatic first versions of a lot of these outcomes. So once all of these are defined, then we have an open access portal where all of these will be deposited. I spoke to Reuven yesterday, so this will be under a sort of a GitHub repository hosted by the BHF Centre. And then we're cross-linking it with other HDR resources like the Phenotype Library and the HDR Gateway. The idea is that once we publish an outcome, we should be able to provide a standalone repository with all the definitions that we used and all the analytical code. So we can tie dissemination sort of outputs with what we actually did in a transparent way. And I think that's, again, we're at a critical position and a very good position to do this and sort of show not researchers, but also patients and the public, that the data can be used for public benefit in a transparent and reproducible way. Along the same lines, this is work that many of us in the Institute of Health Informatics have started examining, working with Sam, who's sort of our captain and lifesaver in many of these issues, is building a pipeline to extract the data sets. So if you're sort of a TRE user, you're immediately sort of get bombarded with many different tables. That's quite difficult to understand where they come from and what the contents are. And as I mentioned before, the quality sort of changes over time. So there's all sorts of sort of challenges in terms of creating even a very simple analytic data set. So the idea is, can we create an analytic data set in a machine sort of driven way? So can we have a configuration file that defines all the study inclusion and exclusion criteria and what the outcomes are, and then combine it with the pipelines that Sam has created to create a 1 row per patient analysis file. So obviously we want this to be flexible. So we want to be able to create the patient cohort that's standardized across all the analyses that want to use the same patient cohort. But then we want to be able to give researchers the ability to add outcomes or risk factors from the sort of a phenotypes table as they wish at different timing windows. So this is something that sort of we're designing, and Alex sort of is doing a lot of great work on this. Our first use case is AMI's direct and indirect effects cohort. So this is a new cohort that we have to sort of start from scratch. But at the same time, we're going to potentially look at replicating the existing cohorts that are ongoing as a validation stage to show that this approach works and that we can actually kind of take a study from a config file to something that can be analyzed in a relevant and relatively sort of straightforward and fast way. And again, the idea is that all the studies within the TRE can use this pipeline to bootstrap sort of new analytical cohorts. But hopefully, as NHS Digital sort of expands more and more users of the TRE in general from different sort of angles, they could potentially reuse some of the things that were built in the TRE for their own settings. So this is just a very, very brief summary that I had from all the work that sort of is ongoing. And there's other stuff that is ongoing that I didn't mention that's just started sort of in the design stage, such as using probabilistic phenotyping approaches in order to move away from this idea of people reviewing thousands and thousands of SNOMED codes and then linking them to finding something that's more data-driven, doing machine learning using unsupervised learning to identify latent disease subtypes, and in theory linking them to, well, not in theory, but trying to link them to COVID severity. And then Hong Han is also interested in phenotyping rare cardiac diseases and finding the impact of COVID on them. So I sort of presented work from many sort of people in the Institute of Health Informatics that are listed on the right, and that's all my slides.
Wonderful. Thank you so much, Spiros. It's really exciting to see the thinking that's going on in your group and with collaborators on how we might kind of pull together a really efficient, automated pipeline, curating phenotypes and subserving the needs of multiple research projects. So thank you. That was really, really exciting. I'm